Hello, everyone. Thank you for joining us today. Welcome to Pediatric Renal Nutrition Academy's live webinar. My name is Elisaveta Johnson. I'm a registered dietitian on the Medical and Scientific Affairs team with VitaFlow North America. We're excited to bring you a live event, live educational activity, and introduce our speaker, who is a well-known and respected pediatric renal nutrition dietitian. Today's topic is the practical management of micronutrient intake in pediatric CKD. Please also note that we are recording this program for later viewing. You can access the PDFs of the handouts in the handout section in the control panel to the right-hand side of your screen. If you are tuning in via phone line, don't worry if you cannot access the slide deck. It will be emailed to you at a later time. Financial support for this presentation was provided by VitaFlow North America, a Nestle Health Science company. The views expressed herein are those of the presenter and do not necessarily represent Nestle's views. The material herein is accurate as of the date it was presented. It is for educational purposes only and is not intended as a substitute for medical advice. This educational program offers 1 continuing education credit for dietitians. You can download your certificate from the handout section in the control panel to your right, and it will also be emailed to participants at a later time. Please note that questions will be addressed following the presentation. However, you are welcome to submit text questions into the questions pane at any time during the program. As with any CE program, questions relating to product will not be addressed. Feel free to contact your VitaFlow representative for further product information following the program. Today, I have the pleasure of introducing our speaker, Christina Nelms. Christina is a seasoned dietitian with over 15 years of experience in pediatrics, primarily working with renal patients. She's held several clinical positions, most notably at Children's Mercy Hospital and clinics in Kansas City. She was a certified specialist in pediatrics for 10 years and a certified nutrition support clinician for 5 years. She has been involved with speaking and educating at local, regional, national, and international professional renal meetings. She is the lead author on book chapters in the Aspen Pediatric Nutrition Support Curriculum and Nutrition in Kidney Disease. She is also a member of the International Pediatric Renal Nutrition Task Force, whose main goal is formulating clinical practice recommendations to enable best practice in nutritional management of children with CKD. She is also recently heading up the grassroots efforts to form a North American Pediatric Renal Professional Practice Group. An educator at heart, Christina teaches nutrition courses through the University of Nebraska Systems, trains dietitians new to pediatric renal nutrition, and is working with us, VitaFlow North America, to create educational events and materials to aid pediatric renal dietitians. Let's give a warm welcome to Christina.
Hello, everyone. We're going to be talking about micronutrients, vitamins, and minerals, and this is an incredibly broad topic. So I tried to cover most of the pediatric literature in what I'm presenting here today, but honestly, there are hundreds of adult studies that I probably could have extrapolated to peds, and I could have spent a year preparing for this webinar. So please know that this is as comprehensive as I felt that I could present today. Our objectives for today are to talk about the role of and issues related to vitamins and minerals in pediatric renal nutrition, which is going to be the lion's share of what I am sharing today, because toward the end I'm going to share what my thoughts are on best practice for assessment and some strategies for supplementation and limitation. But hopefully by thoroughly discussing these vitamins and minerals, you'll be able to come to your own conclusions on what you would prefer to do in practice. My disclaimer is that sodium, potassium, calcium, phosphorus, iron, and vitamin D are really out of the scope of today's discussion. They're whole separate topics in and of itself. So basically, I've covered everything else. And I have dug into this topic extensively in the past. I've shared information that I've done in my research on the listserv. I've coordinated a roundtable discussion and presented the results of that at the annual dialysis conference, but I really felt that it was time for an updated look at vitamins and minerals because there has been recent publications So I'm not going to talk about acute care or CRRT. Those are whole separate webinars. So what I really have determined is that dialysis alters so many things in the body. Really, ideally, we should be looking at every single micronutrient all the time, but of course it is not financially feasible to do so. So we'll talk about the ways to best manage these micronutrients. We'll start, of course, with vitamins, and starting with the fat-soluble vitamins. I wanted to mention here, you'll notice that I'm going to have a cover slide for each vitamin and mineral that I talk about. I'm not going to spend much time on these slides. I just felt that it's a good basic reference for you who are following along to remember perhaps what each of these, especially when we get into the B vitamins. I think sometimes thiamine and riboflavin and biotin all kind of run together, and I teach this stuff to college students. So I thought it was helpful to have for reference a slide that can really summarize what these vitamins do in the healthy body. And I honestly just use the NIH healthcare professional fact sheets for most of these, which are a wonderful reference if you ever just need a quick reference for what a certain vitamin and mineral does. They haven't actually built some pages for some of these vitamins and minerals, so I used a few outside sources, but those are my primary sources. So we're going to start off with A, vitamin A. And of course, we know the rules in vision and that it is one of the most toxic vitamins, that it's one you can actually get toxicity from eating food if you ate liver every day. So we're going to talk about it in the context of pediatric CKD now, because this is one that's pretty hot in the literature new. We've known for years. There was a study in 1983 by Blumberg that determined that even without supplementation, serum retinol levels were high. And there's been several studies by Criley and Phasinger since then that have verified this information. And we've just known that retinol levels are going to be high, and really we've thought, oh, there's not much we can do about it. It's thought, although there is no definitive evidence to prove this, that probably the long-term accumulation is not good for liver health. And so the studies that have looked at this have recommended not using any supplemental vitamin A in chronic kidney disease. However, in 2015, an important study came out of the UK that indicated that 77% of children stages 2 through 5, so as early as stage 2, have elevated retinol levels. And then an early 2018 study by Joyce indicated that 94% of dialysis patients have elevated retinol levels. And in her study, 3 of approximately 50 some children were actually getting a supplement with vitamin A, but the majority were not. Now, what this important 2015 study determined is that retinol levels that are elevated are associated with increased osteoclastic action that breaks down bone, decreased osteoblastic action, the one that builds bone up, and calcium release from bone. We know that supplemental feeding, because by the nature of formula, we know that these vitamins and minerals are added artificially to it. So it's more common with that. And it has been recommended that we check anytime we have hypercalcemia of unknown etiology, serum retinol levels, because there is something, at least for our enterally fed patients, that we can do, which is hopefully choose a formula with less vitamin A, or certainly not supplement with it. And I think that as dietitians, it's easy to use a handy supplement, a generic chewable vitamin, or a generic liquid multivitamin, but the evidence is really indicating that we should not be using supplements with vitamin A in it. Moving on to vitamin E, you can look at the functions of vitamin E there. Now, vitamin E is one that you can actually run a little bit of a high level. So if you use, unless you're using excessive supplementation, it's probably not harmful, even though it's a fat-soluble vitamin supplement. Now, vitamin E is interesting. I think we're going to be seeing more about vitamin E in the literature because the information's all over the place, and which is why you may need to make your own conclusions about what you do. Early research indicated normal levels in CKD patients, with high normal levels in those with CKD or dialysis, and lower in transplant patients. One study showed elevated in 87% of patients receiving a supplement. But then another study showed low levels in 72% of children, normal in 21%, and elevated in 7% of children that were not supplemented. And the recent research really talks about its role in oxidative stress and protection against free radicals. We know that vitamin E can have a protective effect against contrast, for example, and that it may improve erythropoietin-resistant anemia, thought to be because of reducing oxidative stress. One study indicates that plasma levels may not correlate with clinical and intracellular vitamin E deficiency well. So we may be needing to see more research about what's really going on with vitamin E despite the levels. Moving on to vitamin K. You all probably know the role in bone health as well as bleeding disorders. Interestingly, although it's fat soluble, there's no upper limit established. Now, vitamin K, I think, is interesting, and another one that it would be really helpful if we had some more literature. There is quite a bit of adult literature out there, and most of the research indicates low levels, actually, even though it's fat soluble and in theory not cleared well with dialysis. Low levels have been associated with high LDL levels, with implications for cardiovascular disease and bone health, possibly that we're not mineralizing our bones well. And the only study I could find in peds renal was in Russian, so that wasn't so helpful, but there is a lot of literature about antibiotic use and vitamin K in pediatrics, including from a pretty major nutrition support journal, and showing that children who receive long-term antibiotics, a third of them have abnormal coagulation studies and really respond to vitamin K therapy. And a recommendation that I think we could extrapolate to our CKD and especially dialysis patients is when they're on antibiotics, we know our PD kids are often on antibiotics, to assess coagulation studies regularly. And this is completely a single case example, but in my own practice, I had a patient that was having abnormal bleeding issues. She was a PD patient who had been treated for peritonitis, and sure enough, she had a low vitamin K level, and she responded to vitamin K therapy. So we'll move to the water-soluble vitamins now, starting with the B vitamins, going in alphabetical order. Now, a lot of these vitamins kind of run together, and I mostly just wanted these for reference. Thiamine, of course, is known for being one of the first deficiencies that shows up in alcoholics or malnourished patients. This is also true of people with chronic kidney disease, including children. This is one of the water-soluble deficiencies that you'll probably see first because it's dramatic with neurological features. Although there is no single study geared directly toward thiamine, there have been case reports in the literature in pediatrics that children with poor nutrition that were perhaps non-adherent with a renal multivitamin do show signs of Wernicke encephalopathy or dry beriberi. So it is something that's out there. We know that thiamine intake decreases as GFR and consequently appetite decreases. We also know that you do have some thiamine loss through dialysis. This research is in adults, not peds, but that you do reduce serum thiamine levels with dialysis treatments. Some older research indicates that you meet your needs with diet plus supplementation, although some other research would indicate some low levels even after some supplementation. There's a study by Wardy that looked at formula-fed kids that basically indicates that kids who are formula-fed, because formula is pretty complete with many of these vitamins, are already getting enough and the supplement is extra. So we do need to consider that. A study from Brazil showed 93% of kids having intakes below the RDA. How much below? We don't really know, but we know that these kids probably basically need 100% of thiamine plus maybe a little extra to account for dialysis losses. We're going to talk about riboflavin next, and most of you probably know that this is light sensitive and in school learned about the use of opaque milk cartons. So riboflavin has similar implications to CKD. We know that intake declines as CKD progresses. Formula-fed kids probably are getting enough plus some extra. It also, just like thiamine, mildly reduces during a dialysis treatment, and that needs are probably met with diet and renal vitamin combined. Moving on to niacin, this is well known for its use in lipid management and the associated flushing that is with excess niacin intake. You'll notice that there is an upper limit for this water-soluble vitamin. What I've done here is I've listed the RDA and the upper limit just for your comparison and for your reference. You'll notice I've indicated the male dose if there's a discrepancy and separated the female dose if it's different. So with chronic kidney disease, especially in pediatrics, intakes are below the RDA, just like the others. It declines with GFR. Interestingly, there is apparently not great dialysis clearance of niacin, especially since it has an upper limit. This is one that has potential to accumulate in excess. Pantothenic acid, or vitamin B5, like many of these, is very involved in metabolism and coenzymes. This is one that there isn't a whole lot of evidence. One study showed intakes below the RDA, but it's considered to be pretty abundant in food and pretty rare deficiency, which is why there's not a lot of literature in CKD, because it's of little interest. Vitamin B6 is one that actually does have a lot of information related to CKD. You can see here the issues with inadequate amounts or excessive, but there is an upper limit. So there have been early reports of children on dialysis not meeting the RDA. And this is true actually of several studies. And again, many of them show that after supplementation, the needs are met. However, what's unique about vitamin B6 is that in renal disease, the metabolic clearance is altered of its precursor PLP, and you have greater losses with erythropoietin use because you're synthesizing hemoglobin faster, and vitamin B6 is essential to that synthesis. So even though you don't have great dialysis losses, you may with medications, this vitamin does seem to be needed in a bit above the RDA just because of its metabolism and how it's used in chronic kidney disease. Now, most literature indicates that in adult patients, we don't have peds literature, but that you need to give a healthy amount above the DRI to meet needs. Interestingly, though, B6 has a role in immunity, and there's been some literature in adults and soon to be published in peds indicating that post-transplant, we have high B vitamin levels, indicating that we should not supplement and possibly even taper prior to transplant because it could be a concern with cellular immunity markers. So biotin, or B7, you can see the issues there with both high and low, but not any real issue with upper limit. Slight declines are seen in adults during hemo treatments, but typically the levels return to normal, so indicating that this is perhaps less of a concern. This is one where we look at urine levels instead of serum levels, and deficiency is unlikely because the gut does synthesize it, and it is pretty abundant in the diet, even if, let's say, your gut isn't synthesizing it properly. But a major study in adult patients that included 23 patients with CKD, 23 on chemo, and 22 post-renal transplant, compared to 40 healthy controls, showed comparable levels, and concluded that there's no real reason to supplement biotin in CKD. Folate is one that we know well because of its role in megaloblastic anemia with inadequate intake and in excess exacerbating symptoms of B12 deficiency. There is an upper limit for this one. There are still some, but less children on average not meeting the RDA. Now, the JOY study in early 2018 that I referred to earlier indicates that in children who received a standard renal vitamin supplement, so including folate, had normal levels 55% of the time, low 6%, and elevated 39% of the time. So we have results really all over the place, which tells me that folate is one that we might need to look at some issues such as how much dialysis they're getting, whether they're a high or low transporter on PD, and really look at the amount that we're giving these kids. Interestingly, I've found that a lot of these vitamins and minerals that are on the market seem to have not been updated recently, that they seem to be based on older research, and the older research indicating that folate improves homocysteine is valid, but it may not actually help cardiovascular disease risk. So whether we need to be giving as much folate as some of these preparations have is unknown. However, there is evidence saying that folate can improve erythropoietin-resistant anemia, so another factor possibly in deciding whether you want to give folate or not. But most of these kids are getting several times the RDA based on our current vitamin preparations. Moving on to B12, again, it has a role with megaloblastic anemia, neurological disorders. Many of you probably think of this as a risk for vegans, and honestly, this is one that unless you have a vegan patient or some reason that our patients are lacking intrinsic factor, this is more of an issue for elderly patients in our population because it is pretty abundant in a non-vegetarian diet. So most of the research, there are a few reports of low intake in certain populations, especially in developing countries, but most of the research indicates this is one that our kids get enough of. So the JOY study that I've referred to indicated that it's only within normal limits 20% of the time on kids receiving a standard multivitamin preparation, and otherwise it's elevated. So again, it's got the role in homocysteine, but whether that actually matters for cardiovascular disease, probably not. Moving on to vitamin C, and this is one that I found very interesting because there's actually been a lot of recent literature in this, including pediatrics, and I think we all know the famous role of limeys and scurvy, where vitamin C was the first vitamin really discovered, but there is, again, an upper limit for this. So early literature indicates that 80% of children on dialysis have intakes below the RDA. We know that children and adults on dialysis have losses through medication or dialysis. In fact, an average dialysis treatment will reduce plasma levels of vitamin C about 50%. It seems to be the vitamin that is most lost through dialysis treatments. We typically have restrictions on high potassium foods, which may also limit high vitamin C foods. But what's interesting is mounting evidence of the role that vitamin C has in oxidative stress, especially for our hemo patients who may have catheters accessed, and that we may be able to protect against oxidation of lipids and proteins with a little extra vitamin C. Now, kind of jumping down to the end of this slide, the concern with vitamin C has always been oxalate, and adult studies with patients getting anywhere from 500 to 1,000 milligrams of oxalate have shown that that can increase risk for kidney stones, especially in populations where oxalate is a concern. That being said, some of the more recent literature says that perhaps moderate amounts, and this is both adult and pediatric literature, may be beneficial with oxidative stress, because previous recommendations and what you'll see most of the renal multivitamins doing is they usually give 60 milligrams of vitamin C because it's been advised from older literature to not give more than 100 milligrams, and an older recommendation of 30 to 60 milligrams proposed for peds. However, they're showing that perhaps these moderate amounts may even improve lipid levels and uric acid, as you'll see here. So this is an area that I think is very promising, that maybe we should be giving a little more vitamin C than previously thought, but I think there's more research really needed. Moving now to the minerals. And what I have found is that the clearance of minerals really depends on how they bind to plasma proteins. And so, for example, zinc and selenium are more weakly bound, thus those are more lost in dialysis fluid. Magnesium, however, is one that is more bound to protein. It's the last major mineral that I'm going to talk about. Most of the other major minerals were the phosphorus and potassium that I'm not going to talk about today. But we know, you can see here the risks of inadequate as well as excess magnesium. It's involved in a lot of things in the body, and most healthy Americans don't get enough magnesium. However, magnesium has a little bit different function in CKD, and I've been very interested in magnesium lately because chatter among other pediatric renal dietitians and my own experience, I've seen patients with high levels, and I've been concerned about that. And indeed, levels have been shown to be normal or elevated in both adult and pediatric CKD, and especially dialysis patients, higher levels in PD than hemo. However, there's thought that we see these high circulating levels, but there's actually low ionized levels. We know that there's magnesium in PD fluid, and in fact, in the 80s, they lowered the magnesium concentration of a standard popular PD solution because of elevated magnesium levels, but we still see some high levels, and there have been case reports of patients actually being symptomatic with elevated magnesium levels, issues, neurological issues, delayed reflexes. My personal cutoff was always 4. That made me a little bit nervous. However, there is literature saying that magnesium may help reduce PTH values and improve calcification. So one recent study said, should we be shooting for mildly elevated levels? So I guess my conclusion would be that we don't want very elevated levels, but maybe it's okay that our patients ride slightly high levels. Copper is another one that has really mixed literature. You can see the issues with inadequate intakes as well as excessive intakes here. But it's one, when you're looking at protein binding, it's sort of right in the middle, which is probably why you'll see some different results. There's just really mixed literature. Some studies say that levels are high, especially if you're on a supplement, but low levels, even 28% of the time from that JOY study in children who were getting supplemented. Historically in adult patients, higher than controls. So you'll see some studies indicating excess copper. There's a nice study here that indicated low levels of children with CKD and on dialysis. Now, there is possible interaction with medications, which is actually true of several of these vitamins and minerals that we've talked about. But I think copper is interesting because for those of you familiar with the Taylor work from 2015, looking at sodium polystyrene sulfonate, and adding it to formula and what minerals it bound in the formula. Copper was one of those, as well as magnesium and manganese, which probably not as big of a deal, zinc, which is, and calcium as well, which we're not talking about today. Also, my own unit did some work that we published in a small study showing that sevelamer hydrochloride actually resulted in severely low copper levels that responded to high dose supplementation. And actually the sevelamer carbonate probably does not have those same issues, but it is helpful to be aware that some of these vitamins and minerals may be bound or lost through some of these medications. So basically, my conclusion is that most copper levels are normal unless there is an outside reason that perhaps they are not normal. Chromium is one that, again, can be healthy in the diet of healthy individuals. However, in chronic kidney disease, it's mostly associated with environmental and water exposure, and which can actually cause kidney injury and has been the cause of kidney issues in children. It's not dialyzed well, and the longer you're on dialysis, typically the higher levels you have, so we want to avoid this one. Iodine, well known for its role in goiter and using iodized salt. So iodine and CKD, there's not a whole lot of literature in this, probably because most of us use iodized salt. However, interestingly, as we see more and more of our sodium intake coming from processed foods, the majority of salt used in food industry is not iodized because they have to declare that on the label. However, for the most part, it is adequate in most parts of North America. However, in some developing countries that don't have access to iodized salt and the soil supply is high, there is an issue with goiter in some of these countries still. There's just really minimal pediatric CKD information and really not much in adults either. There's small studies saying maybe it's inadequate and that with high urine output, so our polyuric kids could be losing this. But most of the literature is related to toxicity from iodine-containing medications. Manganese, you can review here. It's involved in a lot of enzymatic processes in the body and wound management. Really, there's not a whole lot of literature in manganese, but that 2018 Joyce study that came out in early 2018 looked at this and found that it was normal 60% of the time, elevated 40% of the time. And as long as it's not super elevated, we're probably okay, but it's linked to the water supply. And certainly there are regions, even in North America, that have high water manganese content. And so I think the only thing to be aware of here is if you happen to know that your water in the area has a high manganese content, may not be much you can do about it, but might be a reason to check a lab. Selenium is really interesting to me because there's been a lot of mixed literature on this, and it is involved in lots of functions in the body. I feel it's a pretty important nutrient. And again, there's been a lot of literature in CKD, including children. The Joyce study showed that most kids had pretty normal levels, a little high, a little low, but some other studies showed that even if we have normal levels, we have lower levels in control. And remember, this is on the spectrum of being less protein bound, so more potentially dialyzed off. Low levels in certain disease processes. A really nice meta-analysis showed low levels in adult patients. There was also a study out of Poland showing that all 31 of their dialysis patients had low serum selenium levels, and 46 of their pre-dialysis CKD patients had low levels. So what's interesting is that this is one that it's hard to look at serum levels, and really hair levels are going to be more accurate when it comes to assessing true selenium status, and that possibly even subclinical deficiencies that aren't showing up in serum levels may be affecting thyroid function. So unfortunately, most of us don't have the capacity to test hair selenium in our facilities. What I think is really promising is there's been several studies looking at the use of Brazil nuts. One Brazil nut has an average of 58 micrograms of selenium, and if you want to look at your slide above, you'll see that that actually pretty much meets the RDA for selenium in our adolescents. So perhaps we even need to consider every other day or every third day, especially for our younger kiddos, if they're eating Brazil nuts, because this is a potential of toxicity, but that this can be protective against oxidative stress. There's a lot of literature in selenium and oxidative stress. So zinc It's, again, involved in tons of functions, over 100 enzymes it's a catalyst for, and we know that many of the symptoms are similar to what we see in dialysis patients anyway. So we also know that younger ages have greater zinc losses, so we probably need to be very aware of our infants and toddlers on dialysis because they're at the most risk for zinc loss, and zinc is very important for growth. A meta-analysis of adult patients looking at 128 studies in adults showed that patients have low levels if they're on dialysis. So in countries where malnutrition is more rampant, supplementation with zinc has been shown to improve BMI, improve zinc levels, and reduce leptin. And leptin is thought to be very important for protein energy wasting. It decreases appetite intake, and abnormally high levels are found in CKD and associated with inflammation. So possibly we could help limit protein energy wasting if our patients are supplemented with zinc. Children on dialysis, this is that JOY study, most of which were on zinc as part of the renal multivitamin. Now, the UK has slightly different preparations than we have here in the States, and so those children were standardly supplemented with some of these things that aren't in most of our renal vitamins. But again, really mixed levels with supplementation. Again, I think it's important that we know more about the dialysis status of our kids and more about their diets. One thing that I think is important is that zinc is considered a type 2 nutrient, and a well-known scientist, Michael Golden, really differentiated type 1 and type 2 nutrients. Type 1 nutrients are more cause and effect. For example, vitamin C is related to scurvy. Thiamine is related to neurological issues, where zinc and protein, magnesium, phosphorus, and sodium are type 2 nutrients, meaning they have more of a variety of effects, including growth deficiency. So that's why this is so important for younger ages, because it is so important for growth and development. I want to talk about some other trace minerals or substances of interest very briefly. Most of these are ones that there aren't a lot of information on. For example, sulfur is typically abundant. Fluoride, we're going to talk a little bit more on the next slide. Chloride is a major mineral, just like sulfur, but its role as a micronutrient has not been discussed much in CKD. It's more the discussion of acid-base balance and dehydration. Most of us get plenty because it's part of salt, sodium chloride. And so consequently, when your acid-base balance and renal function is impaired, excess is usually more of a concern in renal disease, which is why there are formulas available to, as well as sodium bicarb as a medicine, to actually improve acidosis. Molybdenum, cobalt, choline, some of these, there are some pieces of literature out there, but I didn't feel there was enough to talk about. Carnitine has sort of a whole different medically managed role. It's a conditionally essential nutrient, and those you see at the bottom are heavy metals, heavily protein bound, and typically a water environmental contaminant. But of some of these other substances of concern, I wanted to highlight a few of them. It's important to know, again, that water contaminants are an issue. And for example, my facility did check annual aluminum levels. Although we're not using aluminum-based binders anymore, there is potential for environmental contamination, well water contamination. And if we're looking at some of these perhaps on an annual basis, we might be able to indicate an environmental or an accidental exposure and hopefully prevent further damage. Fluoride is one that there wasn't even an NIH fact sheet on this, because people pretty well know the role in bone and especially dental health. But this is one that is interesting for CKD. Elevated levels of fluoride are linked to kidney injury, especially in children. Children absorb more than adults, lower excretion, because children are accruing tooth and bone more, and even moderate chronic kidney disease, stage 3, is linked to impaired renal clearance of this. There's a concern that this can alter bone mineralization. We want to certainly avoid fluoridated water for dialysis treatments. But my tip for you on fluoride for today is we may want to be asking our patients if they're using home fluoride rinses or other fluoride products, or to be knowing what their dentist practice are. I'll share another case example from my own practice. We had a family approach us that their dentist was very concerned that the water in their area was almost devoid of fluoride, and the question was whether we should supplement fluoride at all. And what we ultimately decided, whether this was wrong or right, I don't really know. We didn't see any adverse effects. We decided to do 1/4 of a supplement. Now, this child had high urine output. He was polyuric, and that weighed into our decision. We might have made a different decision for an anuric patient. Lead is another thing that's emerging in the literature as a concern. Lead levels in one small study of children on hemodialysis, half of them had lead levels to the point that it was a concern for lead poisoning. The other half had high normal levels, as well as all the CKD pre-dialysis patients in the study. And calcium carbonate can potentially be contaminated with lead in small traces. So just something to be aware of when choosing phosphorus binders, possibly. And a recent study also showed elevated levels compared to control patients. So now that we've kind of reviewed all these different vitamins and minerals, and again, I'll let you kind of draw your own conclusions from what I presented, I wanted to share some of my thoughts about assessment. Now, the first thing that we can do as dietitians is be very aware of signs and symptoms of deficiency. You'll notice that several of these nutrients that I talked about have roles in unresponsive anemia. So we need to, even if our unit has iron and EPO protocols that are medically managed, we should be aware of what's going on with their anemia management for the potential role of micronutrients. Hair loss is a very common one, especially in zinc deficiency. That's one I saw in some of my own patients. And then physical exam, SGNA, that is a whole separate webinar, so I decided just to include this briefly, but just know that common deficiencies that you can look up any textbook or handbook involve examination of skin, hair, abnormal hair growth, eyes, oral cavities, epiphyses, ribs, tibia, and fibula. So some of the things to be looking at specifically for micronutrients. Now, we are busy as dietitians, and I know I didn't have time to do a thorough diet assessment with all the micronutrients every month on every one of my patients, but I would encourage you to consider at least an annual, perhaps every 6-month evaluation that's thorough, looking at their dietary intake and really looking at those micronutrients. Because we tend to get caught up in sodium, potassium, phosphorus, some of those, but we do need to be aware of these and look for changes. And then I think it is very important that we as dietitians are aware, how much dialysis are they getting? Are they getting extra days if they're a hemo patient? Are they a high or low transporter on PD? Because if they're a high transporter, we might be needing to give them more vitamins and minerals. If they're a low transporter, that's the patient we might want to back off on. So when we look at biochemical assays, I think, again, as dietitians, we need to be talking to our labs, or at least perhaps a nurse in our unit who's very familiar with what our lab has as far as in-house and send-out options. Most of these nutrients that I talked about today, serum levels are the appropriate measure. I wanted to highlight a few differences. It's retinol levels for vitamin A, alpha tocopherol for vitamin E. Vitamin K is tricky, and there's been a lot of discussion about the accuracy of vitamin K measures. I'm going to butcher the pronunciation of phyloquinone. Has been very common, but there's recent evidence that PIVKA2 is going to be more accurate. PLP for vitamin 6, it's B6, it's its precursor, urine for biotin, and again, as I mentioned, for selenium, if we could test everybody's hair, that would be great, but probably not realistic. Next, I wanted to talk about strategies for supplementation or limitation, and I apologize that my slide is not moving forward for some reason, but if you follow along in your notes, when we're looking at evaluation, really the best option would be to periodically check vitamin levels and adjust. And I know my unit had protocols for how often we checked things like zinc and copper and aluminum. So if you're able to get some of those regular protocols in place, then you've got hard data. And I know a lot of pediatric facilities have some leeway because pediatric facilities have some more financial resources, but I know that's not always the case. So another thing is to keep some of these physical exam, dietary evaluation factors in mind, and then perhaps if you feel that a vitamin A level, a retinol level is warranted because of hypercalcemia, or a zinc level is warranted because you're seeing hair loss in your patient, I think it's prudent to ask your physician if you can get that level assessed specially. It's always important to look for food intake first. There may be a simple diet change. Let's say our patient likes strawberries, and they could perhaps incorporate that in small amounts in their diet to improve vitamin C intake that's quite low. The Brazil nut example I gave is easy. It's one nut, and that might, even without a lab level, be prudent to encourage our patients to be eating a Brazil nut once or twice a week, just for a little boost, which potentially can help antioxidant status. It's also important to know that appetite and nutritional adequacy declines as GFR declines. So if you've got a patient at stage 3 that's just fine, they may not be by stage 4. So to keep on top of that. Kadoki says it, and I'm going to reiterate it, but a water-soluble supplement is prudent. We need to evaluate what we're using for that water-soluble supplement, as I'll discuss next, but there's, at least for most of them, there's probably not a whole lot of harm in giving a little extra, and we may be able to present a subclinical deficiency. However, that being said, we do need to be aware for our patients who are getting formula or enteral feeds that they may be getting a little bit more, and take that into consideration when deciding if we want to use or what type of vitamin mineral supplement we want to use. Now, these are 2 multivitamins on the market. It doesn't matter which ones, but my point is in looking at comparisons. I wanted to include this as a teaching tool. I've included a chewable multivitamin that's a renal vitamin on the market, and a regular renal multivitamin. And what you can see here is that for our infants, we're greatly exceeding the RDAs, and for our adolescents, we're a little bit closer, but you'll look, as I mentioned, some of these supplements probably haven't been updated with recent literature, because for something that the recent literature says we probably don't even need, that's an awful lot of biotin that you'll see in both of these examples. I found that most of these preparations are pretty comparable. Sometimes they vary a little with folic acid, but most of the time they're pretty similar in what they have. We may not be using a full capsule for especially our infants, but we probably don't want to be crushing a full chewable multivitamin, or we're going to be overdosing our little ones. The next slide, I've pulled 2 liquid multivitamins. You probably can figure out which ones these are if you saw my recent listserv post, but again, it doesn't matter. The point is looking at how these compare. And I had shared recently that I had a kind of a protocol for how much of a liquid vitamin I give per age, and I'm actually rethinking this, and that slide will show that. I decided it probably better to extrapolate between 0 to 6 months and 7 to 12 months. Keep in mind, most of these kiddos are getting formula, so that may be a reason that we might even want to give a little less than these, especially if you've got a PD patient that's a low transporter. But you can see that by giving only a part of a adult dose, which is 5 milliliters, we're more able to give an amount that's appropriate for our kiddos, which is why I'm a pretty big fan of using liquid renal multivitamins, even in our patients who can swallow a pill that are 6, 7, 8 years old, because we can titrate it a little bit better. And certainly one issue we run into, especially as they're on less formula, is that the vitamin C is a little bit low. Of note, with many of these multivitamins, we're exceeding the upper limit. I starred niacin and folic acid because we are at risk of exceeding the upper limits, especially for those kids that are younger. So something to keep in mind. So my suggestions on choosing a supplemental vitamin or mineral preparation is that we want to avoid supplements that have vitamin A, chromium, fluoride, and usually magnesium or manganese. Interestingly, I was working with a dietitian recently. Her physician was concerned that of the cost and lack of insurance coverage of renal multivitamins, but I costed it out, and a standard chewable multivitamin that most kids take was going to be 24 cents a day, and the liquid renal multivitamin was only 25 cents a day on average. So I don't think it's worth 1 cent to be exposing our kiddos to extra vitamin A. We might want to be looking at selenium and zinc, and the Brazil nut option is an option for selenium. Some renal multivitamins do have zinc added to them. I think we need to be thinking more about vitamin C. Perhaps it's something to try if we've got patients with abnormal lipids based on some of the literature. I would also challenge industry to consider creating a pediatric multivitamin. And if I could create the perfect multivitamin, I would recommend moderate amounts of thiamine, riboflavin, niacin, and folate. We know that there's some dialysis loss, so we need a little above the RDA for intake. Probably a little more vitamin C because of its metabolism, but maybe not as much as adult doses. Perhaps bumping that vitamin C up a little bit. Modest amount of these vitamins here that the evidence has shown really most kiddos are getting enough of, and then consider adding selenium and zinc to it. I think we will always need to evaluate copper, vitamin E, and vitamin K individually because there's so many variables in these. And certainly we know with vitamin K, it sort of depends whether they've been on antibiotics. My slide is cut off at the bottom, but really important point, we have to consider pill burden. You know, do we want to be giving an extra vitamin C supplement? Well, we're adding one more pill to the pill burden. So is that worth it? It might be worth it if we're improving oxidative stress or if we're improving lipids, but that's a decision we have to make looking at the individual patient and families. We do have some options with formula alteration. Certainly, we can choose a formula that's lower in vitamin A, and we have formulas to modulate vitamin A status. If we're using other formulas, we can lower that with one of these lower vitamin A formulas. And then sometimes, let's say we need to use a hydrolyzed formula in our patient, we might want to look at magnesium, chromium content, choose one that's lower if we're having to use a hydrolyzed formula anyway, or perhaps a base formula that we're modulating. And vitamin K antioxidants might be nutrients we look at formula in certain circumstances. So my references follow. As I said, I extensively researched this, and so there's a ton of references, and I barely scratched the surface, especially of the adult literature. I might have missed a pediatric study, but I think I got most of those. So at this time, I want to thank you for your attention and see if there are any questions.
Thank you, Chris. This was a very thorough presentation. I feel like I was going back in school. And so we do have a number of questions here. Are those visible to you, Chris?
If you could read them, that would be helpful.
Okay. So we have, I think this looks like a comment here. Just FYI, one of my MDs authored a recent study to be published soon on vitamin C intake and poor bone formation in children. We may still want to be cautious, conservative in our vitamin C recommendations. This was from Christine Benedetti. Did you want
Okay.
to comment on this, Chris?
Sure. Like I said, vitamin C is a little controversial. From what I've read, it's looking like we could probably get by with a little more vitamin C and potentially see benefit with oxidative status, but we do know there are risks. So I'll be really interested to see that study published soon. In fact, I think you should share on the listserv when that comes out, because I think it would be a nice follow-up to the discussion today.
And just as a reminder to everyone, if you want to post the questions, please use the questions pane to your right to type in your questions. The next question we have here is from Laura. Laura is asking, are there any recommendations for mineral additives for TPN with CKD, selenium, zinc, copper, manganese? Do you typically use the DRI as a goal, or is it adjusted for CKD?
Ooh, that's a complex question. That's that's a whole nother webinar topic. But I actually did some research on CRRT in a paper that I didn't quite get published yet, but hopefully will eventually. So there is some evidence that, well, and it depends on the patient. So we probably do need a standard dose of selenium, zinc, and copper in CKD non-dialysis patients, but those needs go way up if you're on dialysis, and especially CRRT patients. There's evidence that there's high selenium losses. So it really depends actually if they're on dialysis. The problem with TPN is that most of the micronutrient preps come as a package. So what my facility did is, for some of the ones that were a little more nephrotoxic, we would do every other day dosing. I think DRI is a good starting place, but not necessary. But again, you have to look at the individual mineral or vitamin.
Okay, the next question is from Kimberly. Are there any more updates on vitamin A toxicities in, I think this means ready to feed, R/T ready to feed formulas, or R/T formulas? Maybe as something I'm not familiar with.
Yeah, I think that's what it indicates. No, there's not. It's so the group out of Vancouver looked, well, actually at magnesium. I am just speaking purely from what another dietitian has told me now, and they found that the content of one of the ready to feed formulas is in what it says it is, but whether it's more bioavailable because it's liquid, whether the fiber content alters things, I think that unless the company does specific testing, we're not going to really know. Unfortunately, there's probably not going to, well, unless somebody decides to take it on. The group that did that vitamin A literature kind of says, well, we know this, check it in hypercalcemia, but we're not sure we can do much about it. I actually talked to one of the physicians in the UK that was on that paper, and I would say that's true of our older kids, although we could certainly look for notable high vitamin A things in their diet, but we do have the option of choosing a lower vitamin A formula or modulating with a lower vitamin A formula to bring down vitamin A content when we have kids with high vitamin A levels.
And there's one more question here from Katie. Do you recommend checking ionized levels for magnesium?
It would be ideal. I don't know enough, to be honest, about the implications for checking ionized versus serum levels for magnesium. We do know that ionized levels tend to be more accurate. So it's probably not a good idea. I don't know, and perhaps somebody else could comment on this, how easy it is cost-wise, availability in standard labs to look at ionized levels versus serum levels.
just giving an opportunity here for comment or any additional questions from our audience. Well, we are right on time at a 2 p.m. Close time. So if there are no more questions, I just want to extend a big thank you for Chris again for preparing this webinar for our audience. Thank you all for your participation, your active participation. We hope that you found this information helpful, practical, useful for your practice in optimizing patient care. I do want to remind everyone that these webinars are recorded and then they're provided on the VIA portion of the VitaFlow website for later viewing, and you are able to obtain CE credit for up to 3 years from the date of the live broadcast. So if you have not signed up to be a member of our VIA community, please do so by going to the VIA portion of the VitaFlow USA website. So thank you all. We hope you have a wonderful day, and we hope to see you at our next educational event.
Okay, that's a wrap.